Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. You know, A Woman's Journey strives to improve your well-being through health education. According to the Journal of Headache and Pain, a recent study points to over 50% of people worldwide have experienced some form of headache disorder. The American Migraine Foundation reports that women are 3 times more likely to get migraines than men. Also, migraine headaches are the 3rd most common disease in the world, affecting 1 out of every 7 people globally. Tonight, we are joined by neurologist Dr. Anne Yacoub, who serves as co-director of the Headache Center at Johns Hopkins. So please use your Q&A on your screen to ask questions to the doctor, who will respond during the last 20 minutes of tonight's conversation. Our webcast this evening will conclude at 8 p.m. And I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance. You can visit their website for additional lectures and courses throughout the year. And now I'm pleased to welcome Dr. Yacoub.
Great. Well, thanks so much for the introduction, Kelly. It's a pleasure to be with you tonight and to talk about updates in migraine therapy and specifically how these pertain to women. So thank you all for having me. I have nothing to disclose. Tonight, we'll cover a lot of different topics. So we'll try to sail through epidemiology and impact of headache, clinical characteristics of migraine headaches, as well as tension type headaches, the pathophysiology of migraine, migraine through the reproductive years, and then acute and preventative treatment of migraine. And specifically updates and newer therapies that may be relevant and of interest. So by way of introduction, headache is the most common symptom that presents for evaluation at the neurologist's office. Headache is a really ubiquitous symptom, which may be a disease in of itself or a manifestation of another condition. And we label headache disorders as being either primary or secondary. A primary headache disorder is a condition in which the headache itself is the disorder, such as a migraine or a tension type headache. A secondary headache disorder is when the headache is a manifestation of another condition, such as a brain tumor or hypertension or bleeding in the brain. And we all really worry about what if the headache is a secondary headache disorder. But it's important to remember that primary headache disorders are far more prevalent. Worldwide, almost 3 billion people have a headache disorder. So this is tremendously impactful at a global level. The most common of these is tension type headache, estimated to affect about 1.89 billion people. There are approximately 1 billion people worldwide with migraine. And to translate that into prevalence, the global prevalence of tension type headache is about 30% for women and 21% for men, so incredibly prevalent. Prevalence rates for migraine are slightly lower at 19% for women and about 10% for men. Despite tension type headaches being more common, migraine is the most common headache which presents to primary care physicians. And that's because by definition, migraine is more disabling than tension type headaches. The Global Burden of Disease study, which is a large global epidemiologic study or review of epidemiologic studies, ranks headache disorders as being the 2nd leading cause of years lived with disability worldwide, and that's second only to back pain. Migraine alone is the 3rd leading cause of disability among people aged 15 to 49 years. So this peaks during the most productive working years of a patient, which results in substantial burden, both for the individual and their quality of life and ability to engage in meaningful participation in activities, but also a really substantial burden to the workforce. Migraine has been shown to impact patients' ability to take care of their families as well and their relationships. So this can be really tremendously impactful to the family as well. And in 2016, migraine alone caused 45.1 million years of years lived with disability globally. So tremendously impactful. I was asked to comment on ethnic differences in migraine. And so this is data from the Global Burden of Disease study looking at prevalence of migraine in different countries. And you can see here that there are different prevalence rates across the world. But my read of this data is actually that migraine is highly prevalent globally and across different ethnic groups. And although geographic variations which exist imply potential genetic causes or environmental or cultural or economic causes or lifestyle or general health variations. Among all these factors, only actually dwelling at altitude has been clearly demonstrated to impact migraine course and increase migraine prevalence. And that's why you see here the red region of Nepal. That's why migraine is felt to be so common there, is because of the altitude. Other considerations are the urban-rural divide and relative wealth or poverty, which are weakly related to headache prevalence in some studies, but not always in the same direction. And these findings are inconsistent and may be generated by differences in access to care as well. Closer to home in the United States, with regards to racial differences, migraine prevalence is highest among Native Americans, followed then by whites, and closely followed by Hispanics and African Americans. Asians have the lowest prevalence of severe or frequent migraines of the major racial ethnic groups in the US. And again, differences in diagnosis and treatment of headache and migraine may indicate racial or ethnic disparities in access or quality of care for minority patients rather than true genetic variations in migraine. Tension type headache, what are the clinical features of this? It's highly prevalent. Again, the most common primary headache disorder. The most symptoms are mild to moderate and therefore rarely seen even in primary care settings. Lifetime prevalence of attention type headache in the general population ranges from about 30 to 78%. And its pathophysiology is not well understood. And I like to say that this is the forgotten younger sibling of migraine. It's been observed that head and generalized head pain and sensitivity is consistently abnormal in people with chronic tension type headaches. And tension type headaches are more likely to develop, tension type headache patients are more likely to develop shoulder and neck pain in response to exercise than healthy controls. Tension type headaches affects women slightly more than men, and the peak age of onset is around 20 to 30 years. And the natural history is really variable. One Danish study showed that when patients were followed over 10 years, about 25% of patients with episodic tension type headaches then converted to developing a more chronic form of tension type headaches, whereas the majority continued to have just an episodic form of the disease. To describe the symptoms of tension type headache, these are generally infrequent episodes of headaches, which are typically bilateral, described as pressing or tightening in quality. Patients will describe a squeezing band or a hat on their head with a mild to moderate intensity. This is by definition not moderate or severe pain or disabling pain. And this lasts minutes to days. And the pain does not typically worsen with routine physical activity, which is unlike migraine. And it's not associated with nausea, unlike migraine, though some light and sound sensitivity may be present. What is migraine now? So this is kind of going to be the focus of the rest of the presentation. Migraine is typically an episodic disorder with significant recovery between attacks. And it's characterized by recurrent attacks of severe headache, autonomic nervous system dysfunction, and in about 1/4 of patients, or reversible neurologic symptoms, which I'll describe in a moment. Some individuals have chronic migraine, which is defined as 15 or more days per month with headache, and half of those being a severe migraine. And despite the development of effective therapies, migraine is really widely underdiagnosed and widely undertreated, which is why I think talks and discussions like this are so important. We'll discuss the clinical features of migraine next. And I think that this graph really serves to highlight that migraine is more than just a headache. And when we think about migraine, we think about a throbbing type of pain, but really this is only one phase of a migraine. We'll start with a prodrome, or the premonitory phase, which occurs in about 60% of migraineurs. And this phase includes symptoms such as fatigue, drowsiness, yawning, impaired concentration, food cravings, thirst, neck stiffness. Not listed in the diagram here include psychological symptoms like depression or irritability or euphoria. And these symptoms may gradually intensify in the hours leading up to an attack. It's helpful to recognize these because when I discuss these with my patients, they recognize these symptoms and, they may not have linked them with their headaches. They may have thought that it was just them, or they were crazy, or it was all in their head. No pun intended, but knowing the premonitory symptoms helps patients recognize early phases of their attack, and that may help signal to patients that a migraine is coming, and they may benefit from earlier therapies once they link these symptoms with their migraine. An aura occurs in about a quarter of patients and is comprised of focal neurologic symptoms that may precede or accompany an attack. The most common of these is visual symptoms. So people get flashing lights or scintillations or bright stars or zigzags in their vision, kaleidoscopes or colors in their vision that may precede or accompany an attack. Other non-visual symptoms include numbness and tingling, trouble with language or speech, and rarely weakness. Migraine aura can also actually occur without a headache, and that's termed migraine aura without headache, which is a descriptive term. The headache then tends to follow the aura and usually begins within 60 minutes of the end of the aura. And then finally, a postdrome. And postdrome is what my patients like to call a migraine hangover. This is where they feel fatigued, sore, like they have a bruised head, and they may have persistent cognitive or concentration difficulties. And this phase actually can last 24 to 48 hours after a migraine. And for some patients, this is even more disabling than the headache itself, just because of its duration and because of the cognitive symptoms that can sometimes happen here. What about the headache itself? So one way to remember the features or the clinical features of a migraine is to use the acronym POUND. So in POUND, the P stands for pulsating pain, the O for 1 day duration. So typically a longer headache, 4 to 72 hours if untreated. If you treat your headache and it gets better quickly, then that doesn't count. Unilateral is the U in the POUND. So typically one-sided pain. The N is nausea or vomiting, and the D is for disabling pain. So by definition, migraine is moderate to severe in intensity. And so this is a nice description of the typical headache symptoms that occur in a migraine. Of course, there are so many exceptions to how a migraine can present, and it can be quite heterogeneous in how it presents, but this is sort of the classical migraine presentation that we think about. Chronic migraine is defined as 15 or more headache days per month. There are multiple comorbidities or conditions that can co-occur with migraine, and these include things like vascular disease. So there is an association between stroke and migraine, particularly in women, and particularly in young women who have migraine with aura. And this risk is increased with smoking and oral contraceptive use as well. So I always counsel my patients who have a history of aura to have a conversation about the use of estrogen-based contraceptives, as well as making sure that if they are smoking, to discuss how important it is for them to stop. There is also an association between congenital heart defects and patients who have migraine with aura, though there isn't consensus on closing these defects or correcting these defects and changes in migraine. There is an unclear association between epilepsy and migraine. And then there are also higher rates of anxiety and depression and comorbid pain disorders like fibromyalgia in patients who have migraine. We will just briefly discuss migraine pathophysiology because we get the question all the time of why migraines happen. Why does this occur? Why is this happening to me? We used to think that there was a vascular event that caused migraine. So we used to think that the migraine aura or the reversible neurologic symptoms that preceded migraine was due to a constriction of blood vessels that led to a lack of blood flow to areas of the brain. And then there was a compensatory vasodilation that then led to the migraine pain and the migraine attack. And we now know that migraine is far more complex and involves multiple different pain pathways and multiple areas of the brain, rather than just being a vascular condition. So a wide range of factors can contribute to the initiation of an attack. And these are listed here in this diagram on the top left. And I really like this diagram that kind of depicts the different developments of how a migraine and why a migraine occurs. And so you can see here that both genetic and environmental risk factors can contribute to the initiation of a migraine. And then there are subsequently variable mechanisms involving multiple different brain structures leading to a migraine attack, and also leading to altered brain connectivity. And this is really a whole brain process. And it involves areas like the hypothalamus, which is responsible for congestion, runny nose, eye tearing, and that's why people sometimes think they're having sinus problems. There's also activation of the visual sensory cortex and the thalamus. So these are brain structures that, activation of whom is responsible for the light sensitivity that people experience. The trigeminal nerve and upper cervical nerves, or the nerves in the neck, are also really important for pain transmission in migraine and sensitization. And that's why neck pain is often a really important part of migraine. And these processes ultimately lead to brainstem activation and the release of, and the development of cortical spreading depression, which is a wave of electrical activity that moves over the brain. And that's thought to be the generator for migraine aura, or the neurologic symptoms that accompany migraine or precede migraine. And ultimately the release of these compounds such as CGRP, and CGRP stands for calcitonin gene-related peptide. And it's a molecule that has been identified to be important for the development of migraine. And other molecules as well, including PACAP, which is pituitary adenylate cyclase activating polypeptide. And that's the topic of a significant amount of ongoing research. The clinical features of a migraine attack then will diverge on the basis of genetic and anatomical and other factors. But I like to explain this because people wonder why they struggle to function during a migraine and why they have so many more symptoms rather than just a headache. And explaining that it's a process that really involves your whole brain can help explain or justify the disability that people experience and the variety of symptoms that people experience. What is CGRP? So CGRP is a hot topic these days, calcitonin gene-related peptide, and it's widely expressed in the central and peripheral nervous system. So it's one of those peptides that is released during migraine. Levels of CGRP in the blood are elevated during migraine and then return to normal after treatment. And infusions of CGRP have been shown to trigger headaches in about a third of patients. And all these lines of evidence indicate the important role of CGRP in the generation of migraine. And so the identification of CGRP as being important in migraine and an important part of migraine pathophysiology has been a really exciting story of translational research, and how at the bench in the lab, CGRP was identified as an important molecule in the migraine process. And the process of developing drugs has really come to fruition, and we now have several different CGRP blocking medications that are now FDA approved for both the prevention and abortive use in migraine. So it's been really exciting to kind of see how this was identified as an important part of migraine pathophysiology. And now we have all these medications that are highly effective and really very helpful for patients to target this molecule. The development of CGRP blocking therapies has really totally changed the way we approach migraine treatment today. So it's an exciting story. We'll pivot now to just talking briefly about migraine in the female reproductive years, because this is really a disease that's more common in women and can have different presentation at different parts of the female reproductive cycle. Menstruation is one of the most common risk factors for migraine without aura in women of reproductive age. And the prevalence of menstrual migraine, or migraine that occurs a few days before or at the onset of menses, is reported to be around 4 to 8% of all women, and about 20 to 25% of all women with migraine. So very frequent and very common in women with migraine. Menstrual migraine has actually been shown also to be more refractory to treatment and can be longer than non-menstrual migraine. So recognizing menstrual migraine is really important because it can be an important source of disability for women. Before puberty, migraine is equally common in both sexes. However, post-puberty, a sex difference emerges with increasing migraine prevalence in adulthood. And that divergence, or that continued increase with age, continues until the 5th decade of life, where it peaks. And it's interesting that these sex differences are preserved across countries and ethnic groups as well. After puberty, again, migraine prevalence increases in women more than men, but data is limited regarding the relationship between menstruation and migraine from menarche to menopause. Migraine patterns may be affected by contraceptive methods as well. And migraine in general tends to improve during the second and third trimesters of pregnancy. And there is some literature that suggests that improvement of migraine during pregnancy, which is thought to be because of the rising estrogen levels through pregnancy, is more likely to occur in women who have a pre-pregnancy history of menstrual migraine. Migraine has been reported also to worsen in the perimenopausal period in women with a history of menstrual migraine. So that period, that perimenopausal period of hormonal fluctuations, can be really quite difficult for women, and especially with regards to migraine management. Women with a history of menstrual migraine may also have an increased risk of the vasomotor symptoms that are seen perimenopausally as well. The prevalence of migraine tends to decrease once hormonal concentrations in the blood stabilize after menopause. So with that, we will pivot and discuss acute therapies for migraine. So when we think about migraine therapies, there are both acute therapies and preventative therapies. Acute therapies are what you reach for when you have an attack or when an attack has begun. And preventative therapies are medicines that you use regularly to prevent the onset of attacks. I will start by sharing that there is so much more than just medications in terms of migraine treatment. So to manage an acute attack, we'll discuss medicines in a moment, but there are behavioral interventions, things like sleep, resting in a dark, quiet place, using some caffeine, temperature regulation, so cooling down, and stress avoidance are all really important interventions. And discussing these with patients in my clinic is a big part of what we do because it can really help empower patients to use non-medication strategies to help to manage their pain. Biofeedback is also a really powerful tool, which can be used as a non-pharmacologic method of aborting headaches. Neuromodulation devices are also powerful non-pharmacologic options for abortive therapy. And we'll focus our talk today on newer options of abortive therapies that we'll get to in a moment. Any of these abortive therapy options are most effective early in the onset of a headache. So the sooner these are used, the more likely they are to be successful. What are factors that influence the selection of acute therapy? So what are features of the headache that help guide our choice of which therapy may be right for you? And there are multiple factors, but I'll draw your attention to the top three here. And these are questions I ask my patients at every visit. So the first is time from onset to peak intensity of their headaches. And in patients with a really rapid ramp up of their headaches, which is in general less than 30 minutes or so, abortive therapies should have an equally fast onset of action. And sometimes patients who have these really rapid onset of their headaches, like no pain or baseline pain to really intense pain in less than a half hour, they may benefit from a non-oral route of entry. So either an injectable medication or a nasal spray, which tend to get into the bloodstream faster. Patients who have nausea or vomiting, in particular early nausea or vomiting, may be experiencing a slowing down of their gut. And this may actually limit the absorption of oral medications. And so in these patients, often oral medicines are not very effective, and nasal sprays or injectable agents may also be more effective or more quickly effective. And then attack stage. So people who, for instance, wake up with early morning headaches, and they may have slept through and missed that really early, milder, more treatment-sensitive phase of the headache, may also require either an injectable agent or a nasal spray, more aggressive abortive therapy because they've missed that early treatment-sensitive window. Understanding patients' comorbidities, and so in particular, the presence of comorbid vascular disease is really important to the selection of acute therapy, as well as how disabling the headaches are and how frequently the headaches are happening. So these are all parts of the conversation that we need to have with every patient who comes into our office considering an abortive therapy for their migraines. Why is treating acute headaches so important? It's more than just to alleviate suffering. That's very important, but we know from large-scale epidemiologic studies that the rate of transformation from high frequency episodic migraine, which we tend to think of as 8 to 14 headache days per month, to chronic migraine is about 2.5% per year. And the most important predictors of that progression from episodic disease to more chronic disease is attack frequency, the frequency of use of abortive medications, acute medications, but also inadequate or incomplete acute therapies. And so when people tell me they're just not responding well to their acute therapies and their headaches are treatment resistant, I want them to be feeling better and have a more effective abortive therapy. But that also, generates my interest because I don't want them to progress to a more chronic disease form. So what are options for acute therapies? These are agents that we had were all we had available up until recently. And the migraine specific category here I'll draw your attention to are the triptans. So triptans were the gold standard of migraine therapy. And they are serotonin receptor agonists, meaning they bind serotonin receptors. And they were specifically designed for acute migraine treatment, and they were developed to cause vasoconstriction, or constriction of the blood vessels, when we thought migraine was mainly a vascular event. And it's now understood that they have far more impact and work on other migraine-specific pathways and not just vasoconstriction, but they are considered a first-line treatment for moderate or severe migraine attacks, Side effects include fatigue, dizziness, and chest discomfort. People can develop some nausea with triptan use, and there are multiple available on the market of different half-lives, and they come in with different routes of entry. So oral medicines, sublingual disintegrating tablets, nasal sprays, and injectable agents. And although overall they have a low incidence of serious cardiovascular events, they are contraindicated in patients in whom who have a history of vascular disease, such as heart attack or stroke, because of their vasoconstrictive properties. And so this really does limit their use to patients who don't have a history of vascular disease. One other thing that I will draw your attention to here is that opiates are on this list, but it's important to note that opiates have limited to no use in acute therapy of migraine, and evidence suggests that these products are more likely to cause harm than benefit to people with migraine. So why do we need non-triptan abortive therapies? There is an increased cardiovascular risk in migraineurs, and especially in patients with migraine with aura. And triptans are contraindicated, again, in patients with a history of ischemic heart disease, uncontrolled high blood pressure, or stroke. And additionally, all the trials that looked at the development of triptans, most of these excluded patients with cardiovascular disease. And so we can't generalize safety data from those clinical trials to patients with cardiovascular disease. And this is the gap that these new therapies have really tried to fill, is what can we use in patients with cardiovascular disease, which is a substantial portion of the population, or who just don't respond to triptans. And so the first of this family is lasmiditan, or Rayvow. Rayvow is a centrally penetrant and highly selective serotonin 1F receptor agonist. So it acts on a different serotonin receptor than the triptans do. It was approved for use in October 2019. There are no associated cardiovascular risks for the reasons we just discussed, and patients with known cardiovascular risk were not excluded from the trial. And pain freedom response rate at 2 hours ranges from 28 to 35%, depending on the dose administered, which is similar to a fast-acting triptan, so very effective. The freedom from most bothersome symptom, which in all these studies is either nausea or light or sound sensitivity, was around 40%, so very effective. A really important safety concern that needs to be highlighted with regards to lasmiditan is with its impact on driving. And so dose-related driving impairment was seen with lasmiditan. And this was, again, confirmed in simulator driving assessments. And so importantly, while lasmiditan can cause some dizziness and some fatigue, even in patients who did not report dizziness and fatigue, lasmiditan did affect their coordination while driving. And so it seems that this affects coordination centers in the brain. And there is now an 8-hour black box warning that patients should not drive for at least 8 hours after use of lasmiditan. So this limits the use of lasmiditan or Rayvow to either the evening or patients who are able to stay home or use public transportation, for instance. There are 3 small molecule CGRP receptor antagonists that are used as abortive medications. So this is Ubrelvy, your Brogepant, Rimegepant, or Nurtec, and then hot off the press, just FDA approved last week, was the Vegepant, which is a nasal spray that was approved as an abortive agent for migraine. Ubrelvy and Nurtec are both oral agents. Ubrelvy is a tablet, and Nurtec is an orally disintegrating tablet. The 2-hour pain freedom for all 3 of these agents is about 20%, so very similar and good efficacy. Unlike triptans, the gepants as a family, again, do not cause vasoconstriction. And so there's therefore no warning in patients who have vascular disease, and there haven't been reports of serious cardiovascular adverse events in the clinical trials looking at these medications. To briefly touch on each of these, your Brogepant, Ubrelvy, was approved in December 2019. It's available as a 50 milligram or 100 milligram tablet. And can be used up to twice per day. Rimegepant or Nurtec is an orally disintegrating tablet, came out in February of 2020. And the results are very similar to your Brogepant with regards to efficacy. The dose form available in the US is a 75 milligram orally disintegrating tablet, and its half-life is longer than your Brogepant or your Ubrelvy. And so it's only used once per day. The Vegepant is, again, a 10 milligram nasal spray that was just FDA approved last week. The gap that this medication tries to fill is for patients who have vascular risk factors, but who need a non-oral therapy for the reasons we discussed sooner. So it's exciting to have a non-oral gepant available now for patients. The other really interesting part of this study is that benefit was seen as early as 15 minutes from the first dose. So it seems like it is rapidly absorbed and rapidly effective. Unlike most nasal spray medications, the most common adverse effects was a bad taste in the mouth, some nasal discomfort, and a little bit of nausea with the medication. So that was a whirlwind tour through migraine abortive therapies, and updates in migraine abortive therapy. We'll shift to migraine prevention. And so what are the goals of migraine preventative therapy? It's important to set the stage with what are we trying to achieve here. So we're looking for an overall reduction in headache frequency, but also a reduction in the intensity and duration of headaches. So headache severity should be lower when headaches do occur, and there should be an improved responsiveness to abortive therapy. So abortive therapies should be more effective in patients who are on preventative therapy. It should also prevent underlying disease progression. The ultimate goal is to improve patients' function and their quality of life. When should we consider starting a migraine preventative therapy? And there, is no golden rule or right answer. There are studies that have shown that when people have more than about 4 to 6 migraines per month, the headache-associated disability tends to increase dramatically. So a number of around 4 headaches per month is a good rule of thumb. That being said, I like to share that if I were having 4 disabling headaches per month that impaired my ability to go to work 4 days per month, I wouldn't be able to function. It certainly would be very troublesome for my work, for my patients. And so disabling headaches or a lack of responsiveness to abortive therapy should signal the starting of preventative therapy even below that 4 headache per month number, in my opinion. A really sad statistic is that only about 13% of all patients who would meet criteria for use of preventative therapy currently use preventative therapy to control their migraines. And so that is a huge lost window of opportunity that can really, change people's lives. Appropriate preventative therapy can really be life-changing and improve function and quality of life so much. Yet only a really small percentage of patients actually are using these therapies. What I like to share with my patients is that up until recently, migraine-specific therapies had not been developed. And so we borrowed medicines from other families, and this was anti-seizure medicines, blood pressure pills, and antidepressants. Not because we think you're depressed, so you're having migraines, or you're having subclinical seizures, or your high blood pressure is causing your migraine, but we didn't have therapies that were specifically developed for migraine. The first therapy that was specifically developed for migraine or indicated for use in migraine was onabotulinum toxin A, or Botox. Discontinuation rates of traditional oral migraine preventative therapies are really high. So only about a quarter of patients who start this patient or start these medications, are still on these medicines a year later. And this is really mainly due to adverse effects and also limited efficacy of these medicines. In general, while these medicines can be effective, tolerability can be a problem. We also often use patients' other medical comorbidities to help to guide our choice of these therapies. For instance, a patient with borderline blood pressure may benefit from a blood pressure agent that will target both migraine and blood pressure. Patients with difficulty with sleep or with a mood disorder may benefit from an antidepressant, and specifically an antidepressant that may promote good quality sleep. And so understanding and leveraging a patient's other medical problems may be a really important part of the selection of which preventative therapy is right for each specific patient. Again, the new and I guess not so new kid on the blocks now are CGRP antagonists. So these are newer injectable or infusion CGRP blocking drugs that have really been a total game changer in the world of migraine prevention. And I listed them all here side by side because I think that's the best way to discuss them, is to compare what's available. So there are 3 injectable agents: Aimovig, which is Erinumab, Emgality, which is Galcanezumab, and Ajovy, which is Fremanezumab. Vyepti, which is Eptinezumab, is an IV infusion that's given quarterly, so not an injectable agent. Aimovig acts on the CGRP receptor itself, whereas the other agents act on the ligand or the CGRP molecule. And so patients can respond differently to a receptor targeting agent or a ligand targeting agent. Across the board, these are extremely effective and very well tolerated. There are slight variations in half-life of these medications, so patients who are having an early wear-off with one drug may benefit from a longer half-life medication. If patients are looking for less frequent dosing, Ajovy or Fremanezumab is available as a quarterly dose form as well, and Vyepti or Eptinezumab is infused once every 3 months, so 4 times per year. These have again really been a game changer in the headache world, and have led to really significant improvements in headache outcomes and quality of life for our patients. In terms of adverse effects or safety, these are, as a class, really well tolerated. The most common adverse reactions are injection site reactions. And so redness at the site of the injection, especially with Emgality and Ajovy. And nasopharyngitis was the most common effect noted with the IV administration. Constipation can be seen with these injectable agents. And we're learning in post-marketing data and in newer studies that a slight increase in blood pressure in patients who are already borderline hypertensive may occur with the starting of these medications. So I advise my patients now to keep an eye on their blood pressure, especially if it was borderline before starting these medicines. This is just to highlight the incredible tolerability of these medications. And so you can see here, NNT means number needed to treat, and NNH means number needed to harm. And a lower number needed to treat means that there are fewer patients needed to be treated in order for this intervention to be effective. And the number needed to harm is, as you can see here with Erinumab, which is Aimovig, over 1,000 for both chronic migraine and episodic migraine. So these reductions in number needed to harm lead to significant improvements in long-term compliance. And we hope that that 13% number that I told you earlier is a thing of the past. What about oral CGRP blocking options? And so atogepant or Qulipta is another gepant that is a small molecule CGRP antagonist. It's given daily as an oral medication. It comes in 3 dose forms: 10 milligrams, 30 milligrams, and 60 milligrams. It is only approved for use in episodic migraine, and it was very effective, or shown to be effective, at reducing 3-month average mean migraine days. The most common side effect here is constipation, and that tends to be dose dependent, as well as some nausea. And then lastly, rimegepant every other day, or Nurtec. So Nurtec is the first migraine agent that was developed as an abortive medication that now has a dual indication as a preventative medicine. So we used to really have this distinction between migraine abortive therapies and migraine preventative therapies. And we would counsel patients to kind of be cautious about how often they were using their triptans or their abortive therapies because we worried about the development of rebound headaches. This is no longer the case with the gepants. And so rimegepant now can be used both as an abortive agent and as a preventative agent when used every other day. Rates of adverse events were still overall low and similar to prior rimegepant trials. And this is really, really helpful in patients who need more flexibility in their migraine therapies. So patients who have seasonal migraines or clusters of migraines, weather-related changes and have a hard time in the spring or the fall where they have frequent migraines, they can use the rimegepant every other day during that period, and then have long periods of relief where they have few headaches or no headaches, and they can just switch back to using rimegepant as an as-needed therapy, and medication overuse does not occur. So that flexibility can be really helpful for patients. And we also encourage patients to use the medicine as early as possible in the course of their headache. Again, because we don't think that medication overuse is a problem with this medication. This is just to highlight the fact that even though there have been so many really exciting recent developments in the migraine world, there are more compounds that are being studied and more targets of research that are ongoing and that are very exciting. In the interest of time, I think we will skip over neuromodulation devices, other than I will share that neuromodulation devices are tools that can be used. They modulate peripheral access to central pathways. And these are devices that can be either applied to the forehead or to the wrist or to the neck, depending on the device, as either a preventative therapy or an abortive therapy for migraine. And when are they useful? They're very useful in patients who are really sensitive to medicines or have multiple medication comorbidities or are on lots of medicines and you're trying to minimize the number of medicines that you're using. Or who are just simply not interested in medication options for whatever reason. They can be used as an adjunct to medications as well. And even though they don't carry specific indications for pregnancy, they are generally felt to be safe in pregnancy. And I use these devices all the time in my pregnant ladies who are struggling and I'm looking for a non-pharmacologic option. So happy to take any questions on these during the Q&A. But we won't review them right now. Many exciting options. So, I'll close by sharing that there has really been a wave of change in the migraine world. And I did my fellowship in the 2016 academic year, and most of the therapies I just discussed with you were not available. So it's been really exciting to be a headache doctor during a time where we can bring new therapies to our patients. And I constantly have to update them on what's new and what's about to become available. This has really led to improved efficacy and a more personalized approach to care and a shift in our practice with more focus on medication tolerability rather than, helping, or patients having to push through intolerable or difficult side effects with older generations of therapies. We can now focus really on more medicine tolerability and just getting our patients back to their functional life and doing what they enjoy doing. I really enjoy working with our headache team. So here is our team at the Hopkins Headache Center. It's really wonderful to be able to share taking care of all these headache patients with them. I love that we are an almost all female physician team or almost all female provider team, and information about our headache center is here. And with that, I hope this has been a helpful presentation, and I'm happy to take any questions you may have.
Wonderful. Thank you so much, Dr. Yacoub. Lots of information, and we have a bunch of questions. So how about we just jump right into them?
Please do. Yeah.
How's that? Okay. Our first one is from Rainus, and the question is, please discuss new daily or persistent headache or chronic persistent headache. Are they, you've mentioned that they're different from migraine, but if you have them all the time, And then also with that two-part, can it change your personality?
Yeah. Yeah, so great. So I'll tackle NDPH, or new daily persistent headaches, first. So new daily persistent headaches are a rarer headache disorder that we don't understand very well. They can be really severe and really disabling, and they are what they're described to be. So a headache that comes on one day and just never goes away. So people will come into my office and say, on February 4th of 2021, I woke up one day with a headache and it's been there since. And this is more common in patients with a history of migraine, but they don't necessarily have a headache history. And about a quarter of these patients, you can identify some sort of preceding a viral trigger, a nonspecific viral infection or a vaccination or something that may have precipitated the development of this headache. But in most patients, we actually can't identify a trigger, and we don't know why these happen. Patients with new daily, so I'll step back by saying there is really limited research on the treatment of new daily persistent headaches, because we understand the pathophysiology really poorly. We understand what the best treatment options for these patients are, even less. The natural history is that about half of patients tend to improve around the 2-year mark, and the other half of patients tend to really struggle. And so this can be really very disabling for patients. Patients who have new daily persistent headaches, who have migraine symptoms, so light and sound sensitivity and nausea, and migraine qualities to their headaches, we treat those with migraine preventative therapies that I've just discussed with you. And so we approach those similarly in the absence of more specific therapies for NDPH, but we are often less effective than in patients with migraine. So that's the new daily persistent headache question. The questions about personality change totally. And I'm glad someone brought that up, both in the pre-monitory phase or the pre-migraine phase, and throughout the migraine, people can be more irritable, more lethargic, can really struggle with personal interactions, and can also feel pretty foggy and have a hard time thinking, which can, generate more anxiety for patients. People can also feel euphoric in the premonitory phase or in the postdrome. And so a wide variety of personality changes or mood symptoms can definitely occur. And I like to bring this up with my patients because it's helpful for them to not think it's just them. And they're not crazy. These are actually it's a part of their migraine. So thanks for bringing that up.
Great. Thank you very much. So that might lead into another question from Melody, who says, she'd like to know, are migraine headaches precursors to Alzheimer's disease or dementia? It's when you were saying about personality, but it's a part of that too, that you were mentioning that perhaps, maybe you can't put thoughts together. And because your brain's sort of scrambling here with dealing with the migraine. So
yeah.
What would you speak to about that?
Yeah, sure. I mean, another great question and another really common concern.
Mm-hmm.
There are studies that look at cognitive function or performance on neuropsychologic testing during a migraine and outside of a migraine, and there can be dramatic differences in memory and thinking and cognitive function. So it's really common for patients to worry that these cognitive changes that occur during a migraine may persist longer term, and that's a really scary thought. There isn't a known, migraine is not a known precursor for dementia or Alzheimer's disease. There are really rare neurologic disorders that present with migraine. These are rare genetic conditions that present with migraine, and patients can develop memory loss or cognitive changes down the line. But these are incredibly rare, and in general, patients tend to have a family history. And so for the vast majority of patients, an improvement in migraine control will result in better control of the accompanying cognitive symptoms. So, great question, but not typically a cause for concern.
Okay, so would you say that migraines, do they have a genetic component to them?
Yeah, definitely. So there's a big genetic component, and it's not like other conditions you may hear about, like Huntington's disease, where there was one gene and then people develop the disease. Migraine is polygenic, so many different genes contribute to the development of migraine. And it's not just genetic, it's a combination of genetics and also environmental factors or triggers that lead to migraine. But, often patients will come in with a strong family history of migraine, and that's, supported by by the literature on this.
That leads us to the next question with Ross, who was saying, are migraines inherited? And and your answer to that is
yes.
yes.
If you have migraines and so do your parents, you know who to blame. Definitely inherited. I ask about a family history of migraine all the time, and I really kind of pause and press most patients if they tell me there's no family history of migraine, because usually I can find one if I dig deeper enough. So yeah.
Right. So along with that, Ross would also like to know, is it unusual to experience an aura with a migraine, but no pain associated with it?
Yeah. So great question. So maybe I'll pause by saying, if you are having episodic neurologic symptom like visual changes, numbness, weakness, you should seek medical attention for that before assuming that it's part of a migraine. But assuming that this is migraine aura, that is not uncommon, especially in people with a history of migraine. Even if it's just intermittent migraines in the past, patients can then develop episodes of just aura or just the visual symptoms and then no headache. So yes, that definitely can occur, and especially in patients with a history of migraine.
Great, thank you. So Kyle would like to know, can you actually feel pain in the brain, or no? And if you're not feeling pain in the brain, because he says he's been told that you can't feel pain in the brain, then where are you really feeling it? That's a good question.
It's a great question. Question. You're right. And so most of the brain does not have pain sensitive fibers, and so most parts of the brain you could touch and not feel pain, or not feel. But the lining of the brain, or the dura, is pain sensitive, and so most of the pain sensitive fibers that you have around the brain are in that lining of the brain, and so that's a really important part of the generation of migraine as well. So are these deeper brain structures that also lead to dural sensitization, leading to migraine. That is an important mechanism.
Oh, very interesting.
Yeah.
So Allison would like to know, is there any connection between the idea of slow gut and or food intolerances with the suffering of migraines?
Yeah. So another really wonderful question. Thanks for asking that. And a complicated one to answer. So I'll kind of break it down into pieces. So the gut has been shown to slow down during a migraine attack. And so that's why people can have poor absorption of oral medications during an attack. The gut really does slow down. And so, yes, gut, we call it gastroparesis, has been shown to occur with migraine. I think second part of your question is about food intolerance and dietary triggers for migraine potentially. And that's a tricky question. So there are lots of proposed dietary triggers for migraine. And these can be really individual. So I encourage people to keep a track of their headaches and try to identify recurring patterns in terms of dietary triggers. There are really common dietary triggers, and these are foods that are high in tyramine, things like aged cheeses, foods that are high in nitrites, like deli meats and hot dogs, artificial sweeteners, foods that contain MSG, among other things. Alcohols like red wines and some beers, fermented alcohols. These are all really common migraine triggers. Beyond that, there are so many migraine diets that you can read about, and there is limited evidence to support them. So I don't universally recommend elimination diets to my patients, because that can lead to a really restrictive lifestyle, and really it can be really difficult to adhere to these medicines. And the other thing is that it's really important as a migraineur to have regular high protein meals, and the caloric restriction that sometimes comes with these diets can actually trigger migraines. So my answer is keep track of, so beyond the big triggers that I mentioned, keep track of what's triggering your particular headaches and try to identify what's individual for you rather than, a really broad elimination diet. I hope that answered that question.
Yeah, very, very interesting. Yes, and I think it does make sense. Like anything, if you keep an eye on something that you're eating, kind of keep a logbook or a journal or whatever, and kind of see a pattern.
Yeah, yeah.
Of,
I think if you are planning for a headache center visit, keeping a calendar of your headaches, and it doesn't need to be an exhaustive diary. It just needs to
Mhm.
be some notes about when your headaches are happening, what you're using to treat them, potential triggers, when you're menstruating, if you're having a menstrual cycle, really just some basic information can really help to guide us in terms of identifying triggers and guiding your treatment.
It's a great idea. Really great idea. So, Dr. Yacoub, the next question is from Rennie, and she'd like to know, when she gets a migraine or she knows she's going to get one, and you take your medicine, and I would imagine this goes for a lot of people, but then you end up getting so nauseous that you end up getting sick.
Yeah.
Therefore, the medicine that you just took is no longer in your system.
Yeah.
So, what do you do about that?
Yeah. So a great point. And of course, the medicine that you're not ingesting is not going to help.
Right.
And so coming
Right.
up with an alternative can be really important. So for my patients who have this early nausea and vomiting, which is not uncommon, you can try an orally disintegrating tablet, so an under the tongue dissolvable tablet. And their, Nurtec or Rimegepant is available as an under the tongue dissolvable tablet. So is some triptans, so rizatriptan or Maxalt, also an under the tongue dissolvable tablet. Or you can try a nasal spray. A nasal spray may also help to bypass the gut in terms of absorption. And then the last option there is an injectable therapy. So there are several different routes of therapy that you can use to help you avoid having to swallow a pill when you're trying not to vomit. So
Sure.
definitely, when patients come in, their abortive therapies aren't working. That's the first question I ask is, how early do you get nauseated? Are you vomiting? Because then your oral pills are just not going to work.
Great. Thank you very much. Our next question is from Randy, and he would like to hear, have you heard about studies using, and I might not say this right, but semaglutide for migraines? Did I put that correctly?
I have not. I have not. So not totally sure what that question is referring to, but happy to look into it offline.
Okay.
Yeah.
Great. Okay, Nancy would like to know if you've had some type of heart condition. I think you mentioned this during your presentation, but in particular after a heart valve repair.
Mm-hmm.
Can you experience new auras and not have migraines, but perhaps get loss of vision and things like that, but you don't actually have a migraine? And does having some type of valve replacement kind of trigger that?
Yeah. So that's a super interesting question. So it has to do with both the procedure and after the procedure. So during a heart valve repair, there can be like a shower of mini clots to the brain. And so people can develop, small strokes, but they can also develop new auras or new visual symptoms. And I think in the context of a recent valvular replacement, it's really important to be seen by a neurologist to rule out a stroke or rule out potentially small seizures or something else that may be happening. But definitely these procedures have been associated with a change in headache pattern, and new auras can develop. It's really interesting because patients with congenital heart defects, as I mentioned, do also, these also occur more commonly, people with migraine aura, and we don't fully understand why that happens, but it may be a similar mechanism. So, and then, the second part of that question is, should patients be treated differently? And it really depends on the cardiac function after the procedure. Patients have normal cardiac function and there are no concerns about vasoconstricting agents, then we can potentially use those medicines. So now in the era of medicines that don't affect the blood vessels, I think that we have more options. We often communicate with cardiologists when these patients, we share a lot of patients with these conditions, and we have a conversation about what, risk and benefit risks and benefits of the different therapies that we have available to us and what makes the most sense for each particular patient.
Great. Well, listen, it looks like we're getting near the 8 o'clock hour, and we could go on and on, as it's such an interesting subject, and really, a lot of people are affected by it. So I would like to thank you, Dr. Yacoub, so much for speaking with us this evening. And she has graciously agreed to respond to any of the questions that were unanswered this evening. So in about a couple of weeks, you'll receive an email outlining the outstanding questions and the answers. So I really do appreciate you taking the time to do that. In the coming weeks, a video of tonight's live stream will also be available on the A Women's Journey website, hopkinsmedicine.org/awomansjourney, under Videos on Demand. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/awomansjourney, for more information about upcoming webinars, our Insights That Matter podcast series, and sign up for our monthly emails. Good night and stay well. See you next time.